This chapter will review most of the pediatric oncology that you need to know. Some of the other oncological problems are discussed in other chapters, for example, bone tumor. So we're not going to discuss that one here. We'll do, for example, leukemias here, but bone tumors is in the chapter on orthopedics. Leukemias and lymphomas. The leukemias are the most common malignancies in children. And of the leukemias, the most common leukemia is acute lymphoblastic leukemia, or ALL. Initially, patients don't have lots of signs or symptoms. They will be nonspecific. They don't last for very long, however. Usually they've been sick for only several weeks before you make the diagnosis. Patients with ALL may have some fever that just typically doesn't go away. They may have some malaise, cold symptoms, and then as the bone marrow is more and more infiltrated, then you'll start seeing some other signs and symptoms associated with that, such as pallor, secondary to anemia, or you can start seeing petechia and purpuric lesions, secondary to thrombocytopenia. Remember, bone and joint pain will be the presenting sign or symptom in up to 1/4 of cases of ALL. So we kind of mentioned that already when we talked about JRA, and we said that patients will have arthritis or joint pain. Well, that's part of your differential diagnosis is ALL. Typically with arthritis, it's a longer course of symptoms than with ALL before it's diagnosed. Petechia will be seen when the platelet count is low. You can also see purpuric lesions and lymphadenopathies. Typically, we say that cervical lymph nodes that are enlarged in children, we think of infections. But if they stay there for a longer period of time, despite treatment, then we worry about malignancies. Also, the distribution of where the lymphadenopathies might be is also important. For example, we're always suspicious with supraclavicular lymph nodes, axillary lymph nodes. Those make us a little bit more suspicious. The diagnosis: the peripheral blood smear will show lymphoblasts. It can also show thrombocytopenia and can show low or high white counts and can show anemia. Many times you may not see a blast right away. The definitive diagnosis will be made on a bone marrow aspiration. And there you will see the lymphoblasts. Here is a peripheral smear, and the arrow is pointing at that clump of blue cells, and those are the lymphoblasts that are seen with ALL. Once the diagnosis is made, and again it's made by bone marrow aspiration, treatment is started. There's a different kind of system for staging ALL because by definition it's already spread everywhere. So it's not like a solid tumor. It's already spread because it's in the bloodstream. But the treatment is, first of all, remission induction with chemotherapy, and then after that it will be maintenance therapy. And I don't think that on the exam they'll get into too much detail about that. But always remember that part of treatment includes CNS treatment, central nervous system. One of the favorite places for leukemia to hide or to relapse is going to be in the central nervous system. And in males, think of central nervous system and the testes. We mentioned that previously. So that part of the maintenance therapy of ALL is going to be intrathecal chemotherapy. Patients come in at certain periods of time and they will receive intrathecal chemotherapy. Radiation therapy is not as useful in ALL because it does not penetrate the blood into the brain well, plus you can have secondary malignancies from radiation. Radiation therapy also causes short stature, so you want to avoid radiation therapy. Chemotherapy IV does not help with CNS because it does not penetrate the blood-brain barrier well, and that's why intrathecal is preferred mode of delivery. Again, remember, relapses are going to be CNS and testes in boys, and so patients, as part of their routine follow-up with the oncologist, they'll check white counts, and they will, in boys, they always do a testicular exam. These patients on chemotherapy are having immune suppression, so they are at risk for infections, particularly once their platelet counts are low due to the chemotherapy. They're at really high risk for a variety of organisms, and also think about pneumocystis carinii, and those patients will require prophylaxis with aerosolized medications. Please remember tumor lysis syndrome. It's not necessarily exclusive to ALL, but tumor lysis syndrome is brought up in this particular section so that you'll remember it for all of oncology, is whenever there is a large tumor load. So in ALL, for example, if you have a very high white blood cell count, when they present with high blood cell counts in the tens of thousands, 60, 70, 80, 100,000 white blood cell count, these cells are turning over quickly, especially once you start them on chemotherapy. You're killing a lot of these cells all at once, and so all of these cells are releasing all kinds of substances, and it can really cause problems with the kidneys. You can have uric acid problems and electrolyte problems and calcium problems. So look for tumor lysis syndrome as a complication of the initiation of therapy with high white counts or with a large tumor load, regardless of what the tumor might be. This is going to be treated, first of all, you want to hydrate the patients very well before you start the chemotherapy. It also helps to alkalinize the urine, and you can treat the uric acid problems by giving them allopurinol or certain new medications that are out now to help prevent uric acid formation. The prognosis for ALL is very good. It does depend on certain factors such as age at presentation, white cell count at presentation, whether it's a B cell or T cell. Those are all factors that are taken into account in assigning a prognosis. A young baby, less than 1 year of age, has a poorer prognosis. Greater than 10 years of age at diagnosis of ALL is also a poorer prognosis, and really high white counts are bad, as a bad prognostic sign. Also, a slow response. If the patient takes some time to go into remission or doesn't go into remission initially, that's a bad prognostic sign. Hodgkin's disease. This is a lymphoma, and it's almost the equivalent of leukemia because it has to do with lymphocytes also, but it is a solid tumor. Hodgkin's disease typically has two age peaks. The age peak that we see in pediatrics is around 15 to 19 years of age. There's another peak at around, in adults, at around 50 years of age. We're not going to deal with that because we're talking about pediatrics. Please remember word association, the Reed-Sternberg cell. That is a characteristic pathologic finding. It's a very large cell with a multilobulated nuclei. There are four histologic subtypes. I really don't think they're going to get into those on the exam. They want you to know what signs and symptoms are and what tests you should order. Sometimes EBV virus, Epstein-Barr virus, is associated. It's a higher association with the non-Hodgkin's, however. And patients with immunodeficiencies may be predisposed to developing Hodgkin's disease. The clinical presentation depends on where the primary tumor is and what it causes. So for example, it could be just a lymph node. It's a painless, firm lymph node, and it's a lymph node that doesn't go away. We typically think of particularly cervical lymph nodes in children as an infectious cause. But if it's not going away after proper treatment, then you need to start thinking of other possibilities, and certainly Hodgkin's is one of them. The lymph node is the most common presenting sign. The supraclavicular lymph node is always considered a problematic one. Cervical ones, we worry about infection, but if you palpate a supraclavicular lymph node, you should start thinking that this child may have a malignancy, most likely a Hodgkin's. Sometimes Hodgkin's can present as an anterior mediastinal mass. This can cause coughing or wheezing, so that the location of the tumor will help determine what the presentation will be. Some patients will present with the classic night sweats and chills and fevers, and please remember itching as some persistent itching associated with Hodgkin's lymphoma. The diagnosis, the best way to make the diagnosis is to do a biopsy of the affected lymph node. When in doubt, take it out. It's better than a fine needle aspiration. Take the whole node out and look at the whole node, and then you'll get your diagnosis. Staging can be done with some non-invasive tests. All patients that have Hodgkin's disease need a chest x-ray to look for any metastasis. A CBC may be helpful. The serum ferritin and copper tend to be elevated, and these can be used for Hodgkin's disease. Patients, once they have the diagnosis, should also have a CT scan of the chest and abdomen, again looking for other involvement, other node involvement. If it's a stage 3 or 4, bone marrow should be performed. There you have the listing. I wouldn't spend a whole time on the staging, but stage 1 is the single node. Stage 2 is 2 or more nodes, but on the same side of the diaphragm. Stage 3 is nodes on both sides of the diaphragm, and stage 4 is diffuse disease. Treatment is going to be determined by the disease stage and the age of the patient. There's lots of different treatment regimens, so I don't think that they're going to really get too specific with you on these. But treatment does consist of chemotherapy and or radiation therapy. The non-Hodgkin's lymphoma is also seen in children. Typically, the child with non-Hodgkin's lymphoma is younger than the child with Hodgkin's lymphoma. This is, again, a lymphocytic malignancy, and there is a definite role for Epstein-Barr virus in the Burkitt lymphoma, the non-Hodgkin lymphoma. This is very common in Africa. Again, just like with Hodgkin's, immunodeficiencies can predispose you to having a non-Hodgkin's lymphoma. These are the subtypes, the lymphoblastic, the non-cleave cell, and the large cell. Again, I don't think they're going to get into too many specifics about that. And with this one also, the presentation depends on the location. I remember taking care of a 10-year-old boy presented with an abdominal mass and constipation. He had been seen for a couple of weeks with chronic constipation, and at one point the referring pediatrician palpated a large abdominal mass, and further workup with CT scan revealed a large tumor, and it turned out to be a non-Hodgkin's. An anterior mediastinal mass can present with respiratory symptoms such as coughing or actual wheezing, and the patient may be mistaken to have asthma when actually he has a mass compressing on his chest. Abdominal masses can present pain, or sometimes a mass can be palpated on physical exam. Non-Hodgkin's lymphoma is very aggressive and is a fast-growing tumor, so when it's palpated, it probably hasn't been there all that long. But since it's very aggressive in growth, it's also very aggressive in death, and these things can really involute quickly, and so you have to be very careful about tumor lysis syndrome with these. A biopsy of the lesion, of the mass, will give you the diagnosis. Non-invasive tests also include CT scans, chest x-rays, just like with Hodgkin's lymphoma. The St. Jude staging system is listed there. Just for you to review briefly, again, it's localized disease, stage 1. Stage 2 is regional disease, but without mediastinal involvement. Stage 3 is mediastinal involvement, and 4 is disseminated disease. The treatment is surgical excision of the tumor. Sometimes the tumors are very big and bulky, and you can't get to them, or depending upon, they may be wrapped around certain structures, but chemotherapy really shrinks them down dramatically. You can see the results sometimes within a week. It just gets smaller and smaller. Some patients will require radiation. And stage 1 and 2 have a very good cure rate. Cure rate means that disease-free at 5 years.